So welcome to the next session of the video series on the scapula. The first series, we looked at the basics of the scapula and scapular dysfunction. Now, let's take that basic information. Everybody's got it now. And we're going to take it to the exam room.
Okay. Well, I think Tim said earlier that's really important in the previous video that we need to check for obvious scoliosis, okay? So we have to assume that that is not the case. And if it is, then you need to address that.
So you've seen this thing kind of sitting over here, and you're starting to figure out what muscles, what causative factors may be going on. Tim, when you see it, what do you tell the patient? Boy,
well, the first thing you have to do is have them appropriately draped so you can see their scapula.
So, Aaron, you think, if you see it, what bells go off in your head?
Well, it's interesting because it always begins with what we see. And so you start to think, is this involved on the level that's actually contributing to the overall symptoms or the overall concern? And so I don't stop there, though, right? So none of us do. And so we have to go on and we employ what we call those corrective maneuvers.
And yeah, going back to the patient's complaint, right? They're there for a reason. And when looking at it, is like with this dyskinesis, how can it be playing a role in there, right? Is it the cause of it? Is it a subsequent effect of being affected by their complaint? Is where does this fit in the framework of this patient's complaint?
Whether it's going to show it inconsequential or contributing. To me, I think you're obligated, if you see it, to make that next step to go through some of these things we're going to talk about next. Is that in agreement? I mean, you don't say, oh, well, that's just the patient, you know?
I think you're right that you should investigate more. And I think if you have a little bit of suspicion, like if you talk about the scapular dyskinesis test, it's not just raise your arm once, right? It can quickly fatigue. And I think you need a little bit of repetition. And then also with the corrective test really helps you identify some of the pathology there. So I think.
And you can't see that nice prominent border, and you got to fatigue them out, whether it's 3 pounds or 5 pounds or doing it 5 or 10 times. So sometimes it's sort of very similar to like this approach of evaluate and reevaluate. What you might not see it the first time, you might catch it the second time.
So that leads directly into the next question. So you see it. Now, what do you do about it? What do you do when you observe this problem?
Like all clinical examinations, being thorough. Right, starting with the kinetic chain, start with the hips, start with the core strength, but then I'll also do my full shoulder range of motion, my strength, and then I'm watching the shoulder.
Yeah, it's a valid point. We have conversations a lot of the times where I say there's a difference between having pathologic symptoms and having the actual pathology, right? And so the labrum is a great example of that, right? So you can have labral symptoms quite often because of the scapula being anteriorly tilted and internally rotated.
So I think the one thing that is important when you do observe it is that you look at it in a couple of planes. So what happens in flexion might not be what happens in abductions.
Well, and I think, one thing that I've seen a lot more of in our more sedentary culture, especially with people spending more time on phones and computers and sitting forward, is the first thing I ask them to do is sit up straight. Because if it's an adolescent, they're not sitting up straight. So that may correct it right there. But oftentimes, too, you see a lot of more just anterior tightness from just very poor postural control. And
situation of activation and function, it can break down several ways in several different places. So the evaluation has to be pretty comprehensive. And the best way to do comprehensive is to do it in a certain staged way that you do basically consistently within variations depending on what you find.
So if I have a good surgeon who's already evaluated that patient, if I have somebody with a little less experience, it probably takes me 15 or 20 minutes, but usually range of motion assessment is something we're going to measure a little bit more objectively with goniometry. Strength, lower trap strength, middle trap strength, serratus anterior.
Okay, so now we've been talking about hands-on, this kind of stuff. Let's look, next question is, we like objective measurements. We like to have numbers. All right, so there's a question I always get, are there measurement and measurement techniques that can really... My colleagues and I have really had a good time putting these together. Hopefully you all will have enjoyed this part of the series. And if you want to see the entire video and others in the series, They will be available at www.kiblerscapulasessions.com. Thank you very much for your interest and have a good day.